old news. Did I?
That's me. That's me. You just have to agree it's being recorded.
I agree. And are my slides still visible online? Yes, they are. Didn't screw things up. So I tend to start with this little slide, because it sets the background to the work that I do, and it's really an old. It's an old paper from 1928 by a Swedish county hospital doctor called Gustaf, who has he's describing an accident, as he called it, where they have transfused leukemic blood. And in reality, what happened here is that they had a patient with a bleeding stomach ulcer, needed a transfusion, and as was the case in those days, they took a donor among the other patients. And so they drew blood from a donor who looked like a healthy man with a strong appearance or something like that, and used his blood as a transfusion. And then a few days later, it turned out that he had a big hematoma, and they found out that he had leukemia, likely acute myeloid leukemia or some variant. And then in this case, both the donor and the recipient died quite rapidly. So Gustaf's question, which is really the reason that he's writing about this, is not answered. And the question is really, can we transmit leukemia through blood transfusion? I mean, leukemia is blood-borne. Leukemia is usually very much de-differentiated to the extent that it might not express HLA and it might not express other antigens that would be recognized as being foreign. So it's an interesting question, but Gustaf at least isn't able to answer it in 1928. And I guess this was overlooked because it took some 40 years or so before someone else tried to study that particular question. And this is a series of papers by an Australian researcher called John Thiersch, who took on a different route and tried to answer this question, where he systematically did this using experimentation. There's some static. Is this me or?
No, I think it is. Maybe you want to put this one online.
Okay.
Maybe they're not on muted.
Yeah, but so what John Thiersch did is he took leukemia and lymphoma cells from affected individuals and injected it into other individuals to see if he could. Fortunately, John did not succeed in transmitting leukemia and lymphoma for some reason. And fortunately, we can't do research like that anymore. So instead, we need to take a different route. And that's yet another 20 years later, where we start computerizing blood donation and blood transfusion practices. And this is really the backdrop to the work that I do, where we try to use data to answer questions like this. So I titled my talk here, Health of Blood Donors, which I think is what you are really interested in, and its consequences for transfused patients, which is what I'm really interested in. So it'll be a little bit of a mix between the two, donor health, recipient health, and the extent to which donors affect recipients. So just a very brief outline here. I'll introduce the main tool that we use in our research, which is called SCANDAT, Scandinavian Donations and Transfusions, which is a big database of donors and recipients. I'll give you a very brief methodological background with some of the problems that we have in our research and that I expect that you might have also in your research. And then some case examples of studies that we published over the years with a very nice example of when I've screwed up. And then I'll try to summarize this and bring on some future perspectives. So just a very brief background to what SCANDAT is. It's really a series of databases where we built this the first time in 2002 or 2002 and 2003. And it's a collection of all the electronically available data on blood donors and blood donations and blood transfusions in Sweden and in Denmark. And in Sweden, it goes back to the 1960s. So the first records that we have are from 1966. In Denmark, it goes back to the late 1970s or early 1980s, depends on whether you look at the donors or the recipients. So we have up to 50 years of follow-up. And in Sweden, it's naturally complete since the mid-1990s, 96 or so. And in Denmark, it's naturally complete since the late 1990s. In the Swedish portion of SCANDAT, we have about 1.5 million blood donors with almost 30 million personal years of follow-up, which means that we can, it's jumping ahead, that we can study a lot of things that are even rare. And then on the transfusion side, we have about 2 million patients that we can follow for close to 15 million personal years. The structure of the data is very simple. It's a very simple relational database where we track the unit from the donor to the recipient. And then we can track health outcomes in both the donor and the recipient. And we can also track a lot of lab data or other types of vital sign data on especially the patients through various registers that we've linked with. In addition, the health outcome data that we have linked to the Scandal database is very extensive, and it boils down to these large nationwide registers that we have in both Sweden and Denmark, where, as examples, we have registers on all hospital care, we have a cancer register and cause of death register, and so on. We also have a multi-generation register, which is very interesting because then we can study things like heritability of blood groups, or rather when blood groups aren't inherited and what that might imply. And then some other things that we've used for various cases. So back to these methodological issues that I mentioned at the start. So there are, as I like to call it, a couple of more or less universal laws when it comes to transfusion research. And I tend to say that donors are healthy and transfused patients are not. And this seems like a truism, but in reality, it's always a problem when you're trying to do observational research on blood donors and transfused patients. Because it turns out that donors are healthy for several reasons. They're healthy because we require them to not have things like hepatitis or HIV, or they're not allowed to be on certain medication. But they're also healthy for the reason that they self-select themselves to be healthy at the time of the donation. And this poses some big challenges, as you will see in a moment. The transfused patients, on the other hand, are distinctly unhealthy because that's why they were transfused. And so when we compare transfused patients to other patients who weren't transfused, the transfused patients always do worse. And I always say to my students and to my collaborators that there's no point in comparing transfused to non-transfused patients because we cannot adjust away these differences with the things that we can measure. So studies where we compare transfused patients to non-transfused patients are more or less always useless or meaningless. They don't tell us anything about the causative nature of the transfusion, say, because they are not allocated randomly. And to hammer in some of these effects, I'll show you some early work that we've done. This is a figure with a standardized mortality ratio of blood donors compared to the general population. And so we have causes of death here for cancer, for all-cause mortality, cardiovascular disease, respiratory disease, infectious disease, as stratified or divided up by year of first donation. And what you see here is that if you started donating in the 1960s, your relative mortality is lower than the general population would be at, which would be at 1, but it's not quite as low as it is among people who started donating in the late 1990s, as in this example. And the reason is twofold. One, the criteria for becoming a blood donor has become much more strict. Second, the ones who started in the 60s, they most often aren't donors anymore. So they're not self-selecting themselves to be donors at this particular time, which makes them more like the general population. And then I showed this to my father, who was a Navy cadet in the late 1960s. And he said, well, we would donate blood because we got £2 and then you could go buy a bottle of liquor. And that was fantastic because you were dehydrated from the start. So you got really drunk for that bottle of liquor that you bought for £2. And so maybe that also did something for the motivation for becoming a donor, which would be relevant. But this sort of healthy donor effect that this is referred to is also partly driven by reverse causation. And this is a complicated figure, but what it shows here is the relative donation intensity, meaning that the donation intensity of blood donors, in this case, who got cancer at time 0. And then the x-axis here is years before the cancer diagnosis. So what you see is that but 4.5, 5 years before the donors get cancer, they have the same donation intensity as donors who did not get cancer. But in the year or two before the cancer diagnosis, their donation intensity goes down, meaning that they stop donating blood because they're getting cancer. So they've not been diagnosed yet, but they've already affected their behavior based on something which will occur, at least that we will detect will occur in the future. And this is convoluted. I showed this to my postdoc supervisor and he said, you can't do it like that. His name was Miguel Hernan, so he's a big shot in epidemiology. And maybe he's right, but at least it tells us something. And the reason, or part of the reason that it looks this way, you can derive from this figure. In this case, we have on the lower left corner here, we have average hemoglobin concentration of blood donors. And the red dotted line is blood donors who got AML. acute myeloid leukemia, and the green line is blood donors who did not get AML. And you see the green line is flat and the red line is distinctly non-flat. And it started going down about a year before they're actually diagnosed with leukemia. So they have leukemia, they just don't know it yet, or they have some sort of early stage clonal hematopoiesis or some other thing, which eventually will be leukemia. And then the fascinating thing is that these donors, they actually start getting transfused, which is here in the upper right corner is the relative transfusion incidence, or the transfusion incidence among the leukemia cases. And as you see, they are actually getting transfused even before they have an AML diagnosis, because they've come in at some point with severe anemia and start getting transfused. I think this is quite fascinating because it tells us something about both the donors and the transfusion recipients, because it turns out that the transfusion recipients, in this case, they don't have leukemia. And so if we were to look at what is the risk of leukemia among patients who have been transfused, we would see that the risk is very high in the beginning because they had leukemia and that's why they were transfused. We just didn't know it, or we just hadn't diagnosed it. Enough about the methods and the background. So a couple of years ago, a colleague of mine in Umeå in northern Sweden and I published a paper where we looked at the short-term health outcomes following whole blood donation. And this is an investigation into really things that happen in the days after blood donation, where we use hospital admission data or emergency room visit data that we have from the Swedish patient record. And when we set out to do this, we were thinking that this will be very nice because we are doing an internal comparison, meaning that we're only comparing donors to themselves. This is sometimes referred to as self-control, but I've seen the phrase quasi-randomized used quite frequently. This is bullshit. This is not quasi-randomized, as I will show you in a little while. But there is certainly something attractive about comparing people only to themselves. And the reason that it's attractive is that we can use a fixed effects type of model, in this case, a conditional logistic regression, where we only compare people to themselves, meaning that we factor away everything about this individual that's fixed. And so return to this idea of the healthy donor effect, because we can partition this into two possible distinct health determinants. First thing is that donors are generally healthy. As an example, I have a chronic disease, which means I'm not allowed to donate blood. Other people with chronic diseases are also not usually allowed to donate blood. And these factors are usually sort of fixed or change only slowly. If you have had leukemia, that's not going to change in the future. You will always have had leukemia, and you will also always not be allowed to donate blood. And so by comparing people only to themselves, we more or less remove this effect. The second thing is that at the time of donating blood, donors feel well, because otherwise they would not donate blood. And this is much more difficult to measure and account for. So we do not remove this effect by fixing on the individual or by comparing people only to themselves. So in effect, this fixed effects models, we only compare, we can only remove the confounding from the first types of factors and not to the same extent on the second. But we might not have understood this fully enough when we set out to do this study, when we ran the analysis, as you will see. But what we did is we set up this cohort analysis of about 1 million blood donors with something in the ballpark of 10 million donations or maybe a little bit more than 10 million donations between 1996 and 2018. And then we compared the 30-day incidence of 16 different events. And we included a priori things like atrial fibrillation and fainting and other things that we could speculate could be related to the. But we also included death as a possible outcome. And we ran the analysis, as I mentioned, using conditional logistic regression, and we used time since the most recent donation as the time scale, meaning that people restarted on the time scale every time they donated again, which is a peculiar approach. And then because if you donate blood at 6 o'clock in the afternoon, it means that you have only about 8 hours left of that day to have a myocardial infarction. So to account for the time of the day of the donation, we incorporated that into the models using simple weights to just account for this. And this is just a very graphical summary of what we find. Here we have 16 different types of events. It's possible to read. Well, can we get rid of this thing somehow?
Yep, we can minimize it or just if I go to more.
Hide, floating,
Hide.
floating.
Hide video time.
Floating meeting controls, yeah.
That's better.
Yeah.
So what you see here is, some cardiac things at the top. And in reality, the only thing that really sticks out, where is my mouse? Point is lost.
Yeah.
It's not there it is.
Yeah.
So in reality, the only things that really stick out here are the expected, fainting and hypotonia. And so there's a transiently increased risk of both fainting and hypotonia. The hypotonia thing isn't really statistically significant with these lines here, but it is when we do this, we treat time categorically instead. So I've highlighted those, and that we know, and it's a nice enough illustration that we find what we're supposed to find. But we also find something which I find absolutely fascinating, that you are actually protected from a bunch of things on the day of the donation. And this is the second health determinant at play here. If you donate blood, you actually have a lower risk of having a motor vehicle accident on the day of the donation. You have a lower risk of dying on the day of the donation. That's not because the donation precludes death, but in reality, it's much simpler than that. If you're about to die, you will not donate blood. And so it's as simple as that. It's reverse causation at play. But I'm just fascinated at the magnitude and consistency of this, because it effectively means that we can use these, simple and attractive approaches to really disentangle the effect of self-selection from the health effects of the blood donation. So it's disturbing for someone like myself who wants to do observational research into blood donation effects. But it's quite fascinating that the simple altruistic behavior thing is such a strong marker of disease or of health. But in reality, donating blood entails a small increased risk of seeking medical care for fainting. It's in the ballpark of one such event per 200,000 plus donations. So it's a very small event or effect. But otherwise, blood donation seems very safe, really. And despite our best efforts, we really can't remove the effect of donor self-selection from this equation. We've done this for plasma donation that looks about the same. It's not published yet, but we're working on that. Just that takes a little bit of time sometimes. The second thing, or applied research that I wanted to bring out, is a study, or is a series of studies where I will go through iterations of things where I've screwed up, where other people have screwed up, and where I think we finally arrived at a nice conclusion. And it really boils down to a series of animal model studies that are quite fascinating. That it turns out that if you connect the circulatory systems of mice, where one mouse is old and one mouse is young, the old mouse gets a little bit smarter, gets a little bit faster, and it gets a little bit stronger. And these sort of parabiosis experiments have been coupled with sort of mouse transfusion experiments, but they show pretty much the same thing. And this, of course, catches the eye of the Silicon Valley people. So they start buying young plasma and young blood. So it's a company formed in Palo Alto somewhere in the US, where they sold young plasma, or plasma from 16-year-olds. So you could buy 2 liters of plasma for $8,000. Seems like a good business, I think, because plasma is not that expensive. But maybe we should start looking at the evidence first. Well, the first evidence of this topic actually comes from the late 1400s, where Pope Innocentius, who I think had a stroke, supposedly this is the first transfusion in history. Well, it probably wasn't a transfusion because the circulatory system hadn't really been discovered yet, so they probably didn't know how to infuse something into an individual. But according to legend, the Pope received blood transfusions from 3 young boys, probably choir boys, and of course all 4 died. So not a very successful event, but this idea of young, revigorating blood is old. But when I started hearing about these experiments, I set out what I thought would be a simple enough approach to studying it. So one of my previous postdocs and I did a very simple matched cohort analysis where we compared the risk of death among patients who had been transfused in relation to the age of their donors. So we identified donors who only got blood from, we identified patients who only got blood from donors below age 25. We only got blood from donors aged 25 and 50, and only 50 or more. And then we did a matched cohort analysis following these patients onwards for the risk of death and so on. The nice thing about this, and the nice attractive thing about this study, is that this is really randomly allocated. You know, at a given time point, if a clinician orders a unit of blood, that the age of the donors who contributed that unit of blood is not going to be related to the age or to the outcomes or the disease severity of the patient, meaning that we have like a retrospectively randomized situation. Very nice and attractive. And for an epidemiologist like myself, it's like you strike gold when you find natural randomization like this. And as you will see here, there was no association between the age of the donor and the probability of death in the recipients. And we thought this was a simple enough study. I was approached by a Silicon Valley billionaire who wanted us to do this study, and I tried to get some money to do it, but they were smarter than me, so they ended up not paying for something I did anyway. But it was quite, this is true. So I'm not saying any names, but it's actually true. But so we were very surprised when about a year later, this paper came out from a Canadian group, where they also look at the association between the donor age and the donor sex and the probability of death in the recipients. And they summarize their findings with this sort of artificially constructed Kaplan-Meier curve, where they are looking at individuals who got 6 units of blood, and they were all from donors age 70 plus, less than 20, etc. And that's represented by all the lines in the Kaplan-Meier plot. There probably weren't any individuals in their cohort who got 6 units from only one of these age groups, so it's by extrapolation. But the striking thing here is that they have a 25% absolute mortality difference after, 8 years or so. Very striking. And for me, that made me very, curious about could this really be true? So let's return to this question at hand. If you are interested in exposure to an unusual blood unit, like a unit of blood from a very young donor, it has a very attractive causal structure here. That exposure will not be driven by the disease severity of the recipient, except through the number of transfusions. So the more units you get, the higher the probability of getting something rare or unusual, right? But there will not be any direct effect of the disease severity on the exposure, because it will only go through the number of transfusions, which we can easily measure and account for. So let's examine these associations. Well, this is from Copenhagen University Hospital in Denmark, where we have the number of units from donors age 20 to 29 on the y-axis, and then on the x-axis, we have the total number of transfusions. Each individual is a dot here. So there are a few 100,000 dots in the plot, but what you see here is that there's a perfectly linear association. And anyone who works with statistics would be fascinated when I told them that this straight line is actually represented by a cubic spline. So even if it's a cubic spline, it's a perfectly straight line. And that's because it's a linear association. It's random processes that work. However, the association between the number of units that you get and the probability of death is distinctly nonlinear. So here we have on the upper hand, we have the hazard ratio for death in relation to the number of red cell units. And you have 3 different transformations here. The green line is a log linear function, and then there's a cubic spline, and then there's a categorical function. And you see the categorical function and the cubic spline, they match pretty well, but the log linear function absolutely does not match. You agree? Well, it turns out that if you re-examine this, there's a linear association between the number of transfusions and the exposure to young blood, and the non-linear association between the number of transfusions and the risk of death. Well, the Canadians adjusted for number of transfusions using a log linear term. So we approached them and told them, we think you've screwed up, and they never commented on that. So we published our findings, and we analyzed our data with their model, finding an association. And then we analyzed it using a very simple model where we account for the non-linear associations, and then the whole effect disappears. And so I thought I was pretty clever at this point, and I thought we'd answer this question once and for all, because it applies also to the donor sex thing. Well, a couple of years later, there's another paper came out from a Dutch group where they show an association between blood units from previously pregnant female donors and the risk of death in the transfusion recipients. And the interesting thing here is that there is such an association that pregnant female blood is bad for young male recipients. And this was really curious to us because in this case, we couldn't really find an obvious error or something overlooked in their analysis. So we were starting to think, have we missed something in our analysis? And I'm not going to spend a lot of time here, but they effectively, we can probably skip this for the sake of time, but this is a little bit interesting here. The message slide, it's a table from their publication, but you see here in the middle here that there is an association between previously ever pregnant female blood units and the risk of death, but it's restricted only to young male recipients. And they used 3 different approaches. They used the no mixture cohort, meaning individuals who received a mix of blood units, they were thrown out, or censored rather, when they were received the mixed. And then the single transfusion unit, individuals who just received 1 unit of blood, who were censored at the time of the second unit. And then a full time dependent cohort where they counted associations or counted units as time progressed. And this is fairly spectacular in terms of what they're finding, because I've always argued that if you don't find any main effects, don't look for subgroups that might be susceptible. It's a sort of conservative approach to epidemiology. But I was still very curious about this. And I was thinking, could this be a true effect or is some sort of overlooked bias? There was one problem with the data. They had no parity information for about 45% of transfusions from female donors. And they solved that by exclusion, which could have been a problem. And then they used really 3 separate analyses: a single transfusion cohort, a non-mixture cohort, and a fully time-dependent cohort. So, as always, the devil is in the details. If we imagine a patient like this, a single unit cohort, they're transfused at time 0, and then they're transfused again a little bit later. Well, in their case, they would actually censor that individual at the time of the second transfusion, which is potentially attractive and simple, but it's also potentially problematic because it's informative censoring. And moreover, the second transfusion would be like a competing event because it precludes death. And this could all be okay. It's okay to break the rules if you know what you're doing. But that determines, or that needs for these competing events to be non-differential. Well, they might not be, because it turns out that female blood units are actually less efficacious than male blood units because they contain less hemoglobin. So the risk of needing more blood is actually increased if you get a female blood unit. And that's possibly the reason that their study was flawed. So what does the data show us? Well, it turns out that they see strong signals pretty much only in the weakest study design, where they look in the single transfusion cohort or the no mixture cohort, where they employ this sort of censoring. So we decided to follow this up, and we ran something similar, but we only used this mixed effect or full cohort with time-dependent exposures. And the result really is that we find no association in a much bigger cohort between sex and parity and recipient mortality, no matter how we divide up the recipients by age and sex, etc. So question unresolved. However, this paper in JAMA that I published with a group of colleagues in the US is probably wrong as well, and I'll show you why. I mentioned at the start of this that this is randomly allocated exposure, and this is an example of that it is actually randomly allocated. If you look in this table from yet another paper, JAMA Internal Medicine by a doctoral student of mine, Yi-Cheng Zhao, you can see here that we've looked here in this case of all transfusions. So the unit of measure in this table is the transfusion. And what you see here is the characteristics of the recipient in relation to the parity and sex of the donor who contributed these transfusions. And if you look across in this table, you will see that all of these factors are more or less entirely distributed the same. The hemoglobin is the same in the recipients, the leukocyte counts are the same, the CRP is the same. It's a randomized exposure. So how can we still screw up? Well, it turns out that the DAG that I showed you at the beginning, or the graph that I showed you at the beginning, is incorrect. Because there's treatment confounding feedback, as we refer to it. It turns out that if you get a unit of blood from a female, as I said, your risk of needing more blood is increased. And it's increased even in the day of the transfusion, meaning that if you get a female unit of blood, you're more likely to get more blood. So when we adjust for the number of transfusions, we're diluting away or distorting and biasing our results. So we need to approach this in a different way. This is a bit overkill, but I like to show off that I can show formulas as well. What we did is we ended up devising a more complicated study design using inverse probability weights, like a marginal structural model. And we realized that we needed to run this analysis on the unit of time of an hour. So the data set was structured with 1.8 billion person years, so a very large data set, especially when you need to do bootstrapping to create confidence limits. But we were then confident that we were able to handle this treatment compounding feedback, and the resulting or ensuing confidence or survival plots looked like this. So absolutely no association between the sex and the parity of the donors and the outcomes of the transfused patients. So how am I for time? Am I running out?
Up there is your.
And when am I supposed to finish?
Well, we have to pass.
Okay, so I'll bust through. I'll bust through then. I've got another few slides, and these are perhaps the ones that are interesting to you guys anyway. So my third example would be studying transfusion transmission. And in reality, the transfusion medicine community in the Western world has been fairly successful since the HIV epidemic at maintaining a rapidly or maintaining a rapid response to new threats to the blood supply. However, I've argued for a long time now that the current approach for detecting transfusion-transmitted disease might not be suitable for diseases that we don't even know are infectious, or that have a very long incubation time, where the link to a transfusion that occurred 20 years earlier might not be evident ever. Or simply for common diseases that occur sporadically very frequently. So given that there's recent data, it's not so recent anymore, but there is data in the last 10 years or so that indicate a possible prion-related or prion-like related etiology behind the whole range of neurodegenerative disorders that are fairly common. This is potentially very problematic. And I'll give you one example of such a condition, which is Parkinson's disease. Because to an epidemiologist and cardiologist like myself, it's quite striking that it's possible to induce Parkinson's disease in mice by simply injecting brain matter from affected humans. And it turns out that if you prepare sort of inoculates of alpha-syn fibrils, which is part of the causative protein in Parkinson's disease, and inject it into the mice into the brain of mice or into the peritoneum of mice, you see this cell-to-cell transmission of these fibrils, of these protein aggregates, and you see gradual loss of dopamine producing neurons, and you see the Lewy body pathology, and eventually you see the mice starting to get Parkinson's disease or something that looks like Parkinson's disease. And this is kind of scary because Parkinson's disease is fairly common, and it occurs sporadically, and it occurs, predominantly in older individuals, but it occurs also in fairly young age. And could it be that Parkinson's disease is transfusion transmissible? And this triggered us to prepare a performance study where we looked for transfusion transmission of neurodegenerative disorders. It's a few years ago now, but we set up this analysis using ScanDat, and we started out with a simple approach for studying transfusion transmission, where we compare recipients of affected donors to recipients of unaffected donors. And you could, in this case, you could formulate it by saying, okay, we have two donors, donors 1 and donors 2, and then we have, in this case, 5 recipients. And then we would essentially say, if donor 1 is affected by Parkinson's disease, are recipients 1 through 3 at a higher risk compared to recipients 4 and 5? It's fairly intuitive if you think of it as HIV. If a donor gets HIV, do we see more HIV in that donor's recipient, right? And so when we look for such an association for different neurodegenerative disorders, hard word to pronounce, we look at dementia in this case, Alzheimer's disease, and Parkinson's disease. We don't see any such associations. The hazard ratio in this case is close to 1 in all instances, with confidence limits, including 1. And then just to test our modeling approach and our programming skills, we did the same for hepatitis, where we know it's transfusion transmitted, and we know it was transfusion transmitted before 91, but not after 91, when it was screened away. And then what you can see at the top here of the table is that it's definitely transfusion transmitted before 91, or before 92 in this case, but not after 92, meaning that we see it when we should, and we don't see it when we shouldn't. So that's the sort of positive and negative control. The alternative way to look for transfusion transmission is to ignore the donors, or at least ignore the health of the donors, and simply compare the risk in recipients 1 through 3 to recipients 3 through 5, meaning that we test for clustering or test for sort of shared increased risk among recipients of the same donor. And we do this using a very simple metric where we effectively count disease events among donors' past recipients. So at every donation, we count how many events of a particular type have we seen in past recipients and how many should we have seen from chance alone. And you can summarize this with this plot here, where we have a donor risk score on the x-axis, which is the number of observed events among past recipients minus the expected events. And in this case, it's for hepatitis. And what we see here is that there's several hundred Swedish blood donors with a very large number of hepatitis events among their past recipients, meaning that they infected a lot of people. And if you're curious, you can see that there's at least one donor with 40 hepatitis events. So that donor probably infected about 40 people with hepatitis. This, of course, is before the hep C virus had been found, but it's still very striking. High-frequency plasma donors can infect a huge number of individuals. So we applied this method to dementia, and the reason is that we were simply curious, could there be like a small group of dementia cases who are infectious, and the bulk would not be infectious? Well, as you see here, the point estimates vary a little bit, but there's absolutely no trend, and there's no such signal that this happens. Or maybe there is a trend, but it's at least not statistically significant. And neither for dementia overall, nor for Parkinson, or for Alzheimer, or for Parkinson, which is not here. But we do see it for hepatitis before 92, but we don't see it after 92. Okay, moving on. So we don't find dementia or Alzheimer's disease being transmissible. But what about these other amyloid beta pathologies? So some of you might have heard that the Parkinson's or Alzheimer's disease is likely related causatively to misfolding or aggregation of a protein called amyloid beta. That in turn is also associated with a disease called cerebral amyloid angiopathy, which causes repeated unprovoked intracerebral hemorrhages. And it turns out that there's a lot of animal model data indicating that these proteins and these conditions are transmissible. And given that they are actually fairly prevalent, the lifetime risk is in the ballpark of 25, 30%, maybe even a little bit higher than that spontaneously. So I'll show you some data from the UK, where it all started with an autopsy study of patients who had died from iatrogenic Creutzfeldt-Jakob's disease. So they'd been infected with contaminated growth hormone. And it turns out that these fairly young individuals who died of Creutzfeldt-Jakob's disease had a very high prevalence of very severe CAA, which they shouldn't at this young age. And so what the researchers did, this was led, I think, by people in London, they went back and actually found old vials stored with from their cadaveric growth hormone vials that they've been treated with. And they found in those vials A-beta proteins, misfolded likely, and p-tau proteins, meaning that they came from some individuals who likely had this pathology. And then they took samples from those vials and inoculated it into mice, which led to the formation of cerebral amyloid angiopathy. And this is kind of scary. That you're able to backtrack is impressive as well, but it's kind of scary that something that these individuals were treated with, 25 years ago or so is still infectious to the extent that you can inoculate mice and still see the same result. So I went to a seminar in London 4 or 5 years ago, and I'd never heard of this before, and we decided that we need to study this specifically in our data. But the problem here is that CAA is not very frequently diagnosed. So we had to resort to some sort of proxy, and we ended up using recurring intracerebral hemorrhage as a proxy. And the reason is that in individuals who have an intracerebral hemorrhage recurrence and there's no provocative factor like trauma or brain tumor, CAA is actually fairly common. So it should be a good proxy for CAA. So we used, as I said, this as a proxy. We decided to use the standard database where we compared recipients of healthy donors to recipients of donors with single or multiple intracerebral hemorrhage without provoking factors. And as just simple Cox regression model looking for the occurrence of intracerebral hemorrhage in the recipients in relation to the cystoscopic exposures. We used the Swedish data as the main cohort, and then we used Danish data as a validation cohort to see if we could replicate what we find in Sweden and Denmark. And then we used a negative control again using ischemic stroke, which is related to many of the other etiological factors behind intracerebral hemorrhage, but not to CAA. And what we find is striking in individuals who receive blood units from donors with multiple ICH. There's a nearly threefold increased risk of ICH among those recipients. It looks about the same in Denmark, but with wider confidence limits and a slightly lower point estimate. Our negative controls with ischemic stroke is distinctly null, with no such associations, indicating that it's not a programming error. We haven't screwed up in that way. And then lastly, if we combine dementia and ICH, which biologically makes sense because Alzheimer's disease co-occurs with CAA very frequently, then that conveys the same risk as multiple intracerebral hemorrhage does. So further indicating that A-beta is the culprit, although that conclusion is provocative and maybe preliminary. So in reality, we see this association, we speculate that it might be driven by CAA, and we speculate that the attributable risk here is probably low, but the CAA prevalence is actually quite high. So the attributable risk might be very high in this case. And now we're moving on with some mechanistic studies to try to get to the bottom and see whether this is correct or not. Lastly, I have a few slides of something that I call agnostic studies. So I'm a firm believer in this concept of researcher bias, that we are biased in what we choose to study. And we should use genetic type approaches with agnostic studies much more than we do. So all of the work that I've showed you so far has been sort of specific hypotheses. Now let's do this agnostically and phenom-wide instead. So just a reiteration of what I just said. So this study was just recently accepted for publication, so it's coming up fairly soon. And what we do here is that we've demonstrated that we can study transfusion transmission using our data. But rather than looking at individual diseases, we said, okay, let's look at all the diseases we could think of. So this is our first attempt at a PheWAS study, phenom-wide association study. So in principle, we apply the same statistical methods, but we just do it many times. And then we use sort of simple methods for adjusting for false discovery. And the ultimate goal of this is perhaps that this could be used as a sort of surveillance tool. Could we run this more or less continuously or repeatedly to see if we detect new threats to the blood supply, if they would occur, like COVID or something else? So the approach is very simple. It's the same as in our studies of neurodegenerative disease transmission or CAA, except that we're looking at all the diseases. So about 1.5 million transfused patients. Follow-up just shy of 5 years in the median, but up to at least 40 years or something in that ballpark in this analysis. And then in this case, we're looking at 1,200 distinct unique outcomes sort of defined using ICD 8 through 10. And then we use the same two-pronged approach with the two different models for looking for transfusion transmission. The first looking for donor effects on recipient outcomes, and the second looking at donor-determined clustering in the recipients. And then we use a combination of FDR adjustment and von Frommer adjustment to maintain the false or the alpha error at 0.05. So what we did is we used the first approach to test each outcome individually, then we do FDR adjustment, and then we do replication or validation, if you will, using the second approach, the clustering approach, and then we do von Frommer adjustment. And so out of these close to 1,200 outcomes, 65 were statistically significant in the first round. 15 of those remained after FDR adjustment, and 13 of those 15 were replicated using the second approach. And then 13 of 13 were validated or remained statistically significant after von Frommer adjustment. So what do we find? Is there anything interesting? Well, turns out that there's nothing very interesting here. We find what we're supposed to find. We'll find hepatitis, we find HIV, and we find some other curious things. And as a cardiologist, I'm curious about the stuff that happens here. We see heart failure, and we see, paroxysmal tachycardia. what on earth is that? Is this, residual confounding that we cannot remove, or could this be something, actually interesting? And so we are trying to drill down into this a little bit further, but the general idea is that I think this is a comforting message for the transfusion medicine community. There's nothing overtly transmitted that we do not know. So we'll see where we get with this. We have some follow-up studies being planned. This is slightly limited by privacy. We were forced to aggregate a lot of code, so we couldn't drill down into what these heart failure cases might be, because this could be amyloidosis-induced heart failure, for example, which would be kind of scary, but we don't really know. So we are trying to drill down into that in the future iteration of the work. So just to summarize, ScanDat is really a research database and it's with up to 50 years of follow-up with donors and transfused patients, which is unique. And thanks to these sort of health outcome registers that we have in Sweden and in Denmark that we collaborate with, we can study pretty much anything we can think of. But we are limited by the methodological challenges like the donor self-selection and the unhealthiness of the transfused patients. And this issue of possible transfusion transmission of cerebral amyloid angiopathy that we've observed could be a scary thing. It could also be some error that we've done, and we're trying to validate, first of all, whether this is related to CAA or some other mechanism. And then we are actually getting access to samples from the US to do actual measures in pre and post transfusion samples in relation to prevalence of A-beta in the donors. So hopefully we can get to the end. And that's all I had.
Excellent, thanks. Really a great tool from donors to receive and come back. Question for Gustaf as well online. I think we have, I can't see anybody online. But,
yeah, we have 30 people online, so okay, I'm going to ask them.
Let us know if there's any question. Any question from people attending here?
And please tell me that I'm wrong, because that's fun.
Can I just clarify the conditional logistic follow-up? So you're comparing the period before donation as they are exposed and then after the exposure?
No, it's actually not before, because few events would occur before. I mean, if you have a myocardial infarction, you're not allowed to donate again. So it's the time, you can think of it as the risk time is 30 days from any donation. So the model only includes individuals who've had a myocardial infarction or a fainting episode or a motor vehicle accident or something like that within 30 days of any donation. And then we're just looking at the distribution of time effectively at which the event occurred. So the exposure in a way is time. And then we're looking, so fainting, it turns out that the faintings among these individuals occurs typically on the day of the donation. Whereas for the other events, it did not occur on the day of donation. It tends to occur towards the end of follow-up. So that's the sort of technicalities of how it's conducted. But it's like a case crossover study, if you're familiar with that design. But it's just relaxed conditions a little bit, and then we just fixed effects regression models to answer. Sorry.
And how do you determine the index donation?
So there's no index donation. Sort of, it's just the first donation after which there is such an event. There were some individuals.
Conditional on the event.
Yeah, it's conditional on the event, and then we're testing effectively where the event occurs, and that gives us like a hazard ratio, if you will, or an odds ratio for the time.
It's on the screen as well. That all the people online.
So have I done something wrong?
No, I'm just
The questions.
yeah. Any questions from the audience?
So you mentioned you've done similar work on plasma.
Yes, and it looks about the same, but the plasma donors are fewer, but they have more donations. So the number of events is slower, but it looks about the same. There's nothing very dramatic about it. We will publish it at some point. It's just we've had other things that are more higher priority. I have a very small research group. It's just me and 5-6 other people. So we're limited by our and we're all clinicians as well. So we can't be that productive. I wish we could, but fine out of that. Anyone else?
Thank you. Thanks for a really interesting talk. I am just interested in, well, I don't know if this is outside the scope, but about screening process and if you found out anything different, because like in Australia in particular, screening relies on people reporting their health conditions and the medications they're on. Did you find out anything interesting about people may have reported differently or that shouldn't have been donating when they still were when you did?
Absolutely. Yes.
Do you mind repeating the question?
Yeah, this is it's a fantastic question. It's actually something we are it's part of the work we're planning for the next iteration of the database. So it turns out that everyone lies. And I'm not saying that donors lie more than anyone else, but the donors certainly do lie. And this is quite fascinating. And it says something about the willingness to donate blood because people really want to donate blood. And if you had leukemia and you got 200 units of blood during your course of treatment, well, I want to give back. And so, I really want to give back, they might say. And so they show up and donate. And, first time they show up, they say, well, I had leukemia and got 200 units of blood. Well, you're not allowed to donate blood. Well, that's too bad. I'm healthy now. It's like, but no, you're not allowed. So we do have individuals who have conditions that they should not be allowed to donate blood. Absolutely. We've not looked at that systematically, but we are planning to. And that, in turn, is actually triggered by the fact that we know. Let's put it this way. In Sweden, we are one of the few countries in the Western world who not using NAT screening for blood donation. So we're not using PCR-based technologies to screen for hepatitis and HIV and so on. And we've had no events of HIV transmission since 1985. So that obviously works. But there's, for good reason, they've changed I'm not a blood banker. I don't work with these things, but they have changed the rules for men who have sex with men. And there's a fear now that might increase the risk. So there's discussion of using that screening. Well, in the US, they've recently performed a series of studies where they test for PrEP. And some of you might know what PrEP is, pre-exposure prophylaxis. It's effectively people with high-risk sexual behavior, high risk of HIV, they take HIV treatment prophylactically because it reduces the risk of getting HIV. Well, obviously, if you have a high-risk sexual behavior, you're not allowed to donate blood. If you're taking HIV treatment, you're not allowed to donate blood. But in the US, in certain cities, a handful of percent of blood units, they were able to detect PrEP substances in the blood. And the scary thing about it is that PrEP actually can mask an HIV incident. So if you get HIV and you take PrEP, you might not develop antibodies, which in Sweden would be a catastrophe because it means they would not test positive. So we are linking all our data, our donation data, to a prescription register to test if there are individuals who donate blood who are on PrEP. And we're doing this systematically, looking also for other medication like platelet inhibitors and things that you're also not allowed to take when you donate blood. And this is not to poke fingers at donors because, they're all necessary. It's just a matter of understanding the psychology between wanting to donate and the motivational factors, which are quite fascinating. Why do you want to donate blood? What's the reason for that? I mentioned at lunch that we've actually done a twin study on becoming a blood donor, and the heritability is very high. It's like 55%. I may have misremembered this a long time ago, but it's in that ballpark. And the reason for that is unknown. So that would be a very nice thing to get to the bottom of.
I'm curious about, you get some, you give the Parkinson example. I remember we did this candidate gene almost 20 years ago. Do you have more like perspective in that aspect, like genetic data?
So sadly, we don't have any genetic data in Sweden. There's a big Danish study called the Danish blood donor study where they have a lot of genetic data. So personally, I would love to have some more data to be able to look for, genetic determinants of becoming a blood donor. That would be a really cool study to do. I'm sure you would have some problems with sort of ethnic admixture and stuff like that, but it would still be a cool thing to study. So sadly, I don't have any such specific data.
It might be a silly question. Do you think that, or is there any evidence you've seen that when you have like a short-term reaction after giving blood, like instead of having like, so versus like you being diagnosed with leukemia after you're you're donating blood, if you have a short-term reaction, let's say fainting or whatever it is that at all related to the recipient being at greater risk of any kind of disease?
Very good question. And I let's put it this way. I don't think so, but I haven't looked. But it would be a really interesting thing. I mentioned to Emanuele that one of the things that we are working on right now is that we have linked our data to a big ICU database where we have, continuously measured vital signs for like 20,000 transfused patients. So we have minute by minute vital signs. And you can then say, okay, let's do a pre-post transfusion, difference of oxygen saturation or something like that, right? And then you can compute that for every donor. What is their average pre-post transfusion oxygen saturation difference? And it turns out that there are some donors who tend to induce like a lower oxygen saturation in the recipients. Whether that's related to the donor having some sort of stress reaction or hypertensive reaction is unlikely, but at least there are donor factors that we don't really measure, that we don't know what they are, which could influence outcomes in recipients. Now, the thing we have in mind when we do this is, of course, TRALI or milder versions of TRALI, sometimes referred to as TAD, transfusion-associated dyspnea. But the general idea is that I'm just inherently curious about seeing if we can detect or identify donors that aren't good. And that's not in the sense that they're not good, good boy donating blood, but rather, are there donors who have negative effects on their recipients? That's the general idea.
Good. Any additional questions from Gustaf?
Any online?
Yeah. There's something in the chat. I don't know if it's a question.
No, I think the chat is just people responding to one of my questions.
Okay.
But can they hear the questions? Because this side of the room doesn't pick the microphone.
I'm sorry.
Side. Yeah.
I should repeat the question. You told me that.
I think people said they broadly heard them.
Good. Well, thank you very much.
Thanks
for listening.
Thanks. Good. Thanks for coming.
Yeah.
And thanks for everyone for attending.
And thanks to everyone online. It's a great group. So yeah, really, really excellent, really interesting work.
Thanks.